The next presentation will be given by Dr. Vaezi and Dr. Omari. The title of this presentation is Where Do We Go From Here? Dr. Michael Vaezi is director of the Center for Swallowing and Esophageal Disorders and professor of medicine at University of Vanderbilt, US. Dr. Tahar Omari is a senior research fellow and professor of the NIH MRC, and he's a fellow at the College of Medicine and Public Health and the Flinders University in Australia. Finally, there will be a panel discussion that will be chaired by Dr. Sabine Roman and Dr. Ronnie Fass. Sabine was already presented, and Dr. Ronnie Fass is the medical director of the Digestive Health Center at the Metro Health Center in Cleveland, US.
Hello, everyone, and thank you for the invitation to be a part of this important meeting. I'm sorry that this can't happen in person, but I'm sure we all understand the reasoning. I was asked to put this together, and the title of Where Do We Go From Here? It's a bit challenging as far as knowing where we go, but what I thought I would do is sort of put things in perspective, and my focus will be slightly different in that I'll focus predominantly on the reflux component. I will not discuss the high-resolution manometry and workup of dysphagia, which has been covered by my colleagues. So where do we go from here when it comes to reflux testing? That's going to be the focus of what I will talk about. Well, when we discuss reflux testing, we're really talking about different presentations. So we know that we do slightly different things for patients that present to us. We already know patients presenting with esophageal syndrome or extraesophageal syndrome, and we all have our own biases about which one might be reflux related, which one might not, but I'm going to not discuss any of that and focus predominantly on what is our role in a patient that we anticipate we're going to do reflux testing and determine whether there is reflux and whether that's contributing to whatever that symptom presentation is. So right now, majority of the patients that we do procedures on for reflux are those that we're calling refractory GERD. Let's change that to really refractory symptoms. So a patient presents with a symptom, we think it might or might not be reflux, and for that reason, we do diagnostic testing. The issue with diagnostic testing is that there are many of them, as outlined here. Which one do we pick? Do we want to measure acid? Do we want to measure bile? Do we want to measure symptom indices, wireless, catheter-related, pepsin assay, oropharyngeal impedance, biopsies, and looking at dilated intercellular spaces? All of which have been well studied, and I won't go into details other than here are the tests that we do. Well, I want to step back a little bit and say where we are, where we were, and where we are. Back then, when reflux testing, especially catheter-based pH testing came about, which was around in the 80s, if you will, and then 90s, we were really looking at a different population. In the 80s and early 90s, we only had H2 receptor antagonists. We did not have PPI therapies. So the pre-test probability of reflux in many of our patients was high. When we did endoscopy, many patients had esophagitis. When we did the pH testing, ultimately, many might have had abnormal reflux. Now we're dealing with a different concept in that PPIs are well prescribed and are over the counter in many of the countries. And given that patients that present to us are PPI refractory patients. So what is the likelihood that that patient has reflux is different now than it was back then, given the therapeutic options that were available. So many of our patients have normal endoscopy, and when we do testing, we are not overwhelmed by the findings. That leads to many other tests. So we look for alternatives. which there's nothing wrong from a research perspective, but at the end of the day, I think we might want to pause and say, is this really reflux? I think any test and any advancement in the field perhaps might be a pause and stepping back, if you will, rather than continuously looking for a more sensitive way to diagnose reflux. And this essentially outlines what we had then as far as pretest probability of reflux versus what we're looking for now. And even the ones that have reflux based on whatever test you pick, could that be an overlap with, say, functional symptomatology or other non-reflux related? So those are the things we have to pay attention to. This slide outlines the fact that I already mentioned. Many of our tests, no matter which one you favor and whether you want to do it on or off therapy, still majority of patients have normal findings. So that puts us in a different category. The tests we want are those that are more specific. We want to have tests that tell us the patient doesn't have the disease, but also those that it can pick up those that have, say, mild to moderate symptomatology. With that, I'm sure you've read and you're familiar with the mucosal integrity testing that has come about as I'm discussing new technologies and where we go from here. Perhaps this device or devices such as this could advance the field of diagnostic modalities. And the reason it potentially helps are twofold. One is that the information we get is during endoscopy when the patient is sedated, and it takes us an extra few seconds rather than waiting 24 or 48 hours, or depending on our pathologist or electron microscopy to give us some answer. So perhaps this is an advancement on the ease of technology and more information than we're used to. And with this is a picture of that mucosal integrity that is taken during endoscopy, and you can see that the electrodes are opposing the mucosa 180 degrees apart, and this technology allows measurement of epithelial changes over a 10 centimeter segment of the esophagus. So you're getting a axial and radial information, which perhaps is better than a probe placement at a specific site and measurement for only a day, rather than measuring chronicity of the disease and its impact on the epithelium. The other thing I wanted to emphasize regarding this technology is the cutoffs and the probabilities. We're all used to cutoffs. And in fact, what I'm about to tell you is going to make you uncomfortable in that everything we do is based on norm or abnormal, right? So think about reflux testing. When pH testing, we talk about using 4.2% as a cutoff of normality, or 5.5% with the Lyon classification, perhaps 6 or above. We have the Meester score. We have SI-SAP. If you're above a certain percentage, then it's abnormal. 95% SAP, 50% SI. So you could really see with impedance testing, Bilitech, Pepsin, all of these, we're really dichotomizing the information. And perhaps another way to go forward is to look past dichotomization and look at the fact that physiologic measurements are not dichotomous. Makes us feel better. It makes it easier because you can say you're normal, you're abnormal. You can tell the patient that, but perhaps that's not the way to diagnose a physiologic disease. Perhaps there's a spectrum, as we all know, and using that spectrum to come up with probabilities. With the mucosal integrity testing, we can use cutoffs. So here's a slide showing EOE measurements along the esophagus, reflux measurements, or the norm. So we could use a cutoff here. We can say, all right, above 2000, that'll make us feel better. There'll be a certain sensitivity, specificity. But what we know is that there's overlap in any physiologic measurement. So perhaps we should look at probability. What is the probability of disease in a patient that presents with a certain symptom that has certain findings? What is that probability? And I think that is what we do, globally speaking, in our minds, in that, we say, well, this patient most likely doesn't have the disease or most likely has it, and we're using that probability, but not in a measured way. So mucosal integrity uses that probability in that whatever the values are on the intercept and the slope, it comes up with a probability. So when you look at the software, at the end of the measurement, it might take you an extra few seconds, tells you that in this case, the probability of reflux is 67%. It doesn't tell you that this patient has reflux. It says, based on this specific measurement, there's a probability 67%. Let's say this is a patient that you have heartburn and regurgitation, and when you've done endoscopy, there may be a hint of esophagitis, or let's say there was a hiatal hernia, and the patient's symptoms fit, then you would say, all right, this patient has the disease. However, let's also say that this patient doesn't fit reflux. You don't have to make that diagnosis based on a single test. We're all familiar with the fact that we use all of our diagnostic tests as pieces of puzzle, and if one doesn't fit, then we look at the other tests rather than the single. And this is similarly used in that fashion, but I would argue that one additional advantage of this technology is using probabilities. And whether we use this technology or others, I think we should step away from the dichotomization measurements. At least that would be my recommendation. So could a future state algorithm in reflux measurement be simplified rather than a very complicated measurement of you have SI that's abnormal, SAP that's abnormal, you do X, you do Y? How about we just decide whether someone has the disease, and simply once empiric therapy is done, patient symptoms persist, you do endoscopy, perhaps mucosal integrity, and if it's normal, you look for other diagnoses, and norm being based on probability measurement. If symptoms improve and you want to send the patient to surgery or endoscopic therapy for reflux, then you take them off to make sure they have the disease. And if symptoms improve and you're not planning on doing anything else, you could titrate the medication. So I don't know where we will be going, but I hope where we will end up in a few years will be simplification of the process and moving away from dichotomized measurement of normality. The only other thing I would mention regarding treatment for reflux, we know that there are now studies looking at P2X3 receptor inhibitors as possibility for treating patients that might have functional symptomatology or sensitivity, if you will. And this is neuromodulation method. And then we have PCAPs. This is available in some countries, but not others. In the US, there'll be studies that will be looking at that and its role in reflux disease. And endotherapy, endoscopic or minimally invasive therapy for reflux, for it to find a role in some of our patients, but not necessarily those that continue to be symptomatic and don't have the classic symptoms for reflux and are not responsive to therapy. But the point being, treatment must be advanced as is, and our diagnostic test might fit that as well. Great, thank you. It's been a pleasure, and I look forward to the Q&A session.
Well, hello, and I'd like to thank the organisers for the opportunity to discuss where we go from here. So in version 4 of Chicago classification, the protocols have been expanded considerably with scope to add additional aspects on a case-by-case basis, as well as other tests to confirm, for example, EGJ outflow obstruction. In Chicago 4, the key metrics and phenomena that are used to define motility disorders are the same as were in Chicago 3. One direction that we can take from here is the validation of metrics that require impedance for their derivation. Intraluminal impedance is, of course, the companion modality that may add to the diagnosis of esophageal dysmotility by high-resolution manometry. There is obviously a long history of use of impedance that I won't go into over this short talk. Suffice to say that I think there are some obvious targets for research that I, for one, will be pursuing to examine if they're offering diagnostic improvements. So where are we now in terms of intraluminal impedance and Chicago 4? Impedance did formally receive some attention by the working group. acknowledgement that poor transit on impedance could provide support, albeit of a low grade, for diagnosis of IEM, and for rumination spectrum disorders where impedance can detect and characterise abnormal gas or liquid flow in association with rumination behaviour. Importantly, the working group opened the door for a future role for impedance in assessing intrabolus distension pressure and esophageal emptying through the esophagogastric junction, providing a recommendation that impedance can be used to measure these phenomena, but making it clear that it is not required for Chicago version 4. When I think about where we are in 2021 and how we are taking advantage of impedance, the word that comes to my mind is confidence. We are becoming increasingly confident that impedance does not just represent bolus presence or stasis, indeed that impedance may provide diagnostically relevant insights into luminal distension. We first took note of this when we observed how well impedance could record changes in diameter in animal preparations, and showed this to be true in humans radiologically in upper sphincter and in esophagus. Dr. Mittal's group also confirmed this using the far more elegant and accurate intraluminal ultrasound technique, showing that impedance, or its inverse, admittance, corresponds to cross-sectional area. And they recently showed that a standardized conductivity bolus media enhanced the accuracy of this correlation, something that we have suspected for a long time, but it's really nice to see the clear experimental evidence to show it. Using methods based on those developed by Dr. Palfino's group, we can integrate pressure and impedance recorded within the esophagogastric junction to directly predict conditions of bolus presence and pressure gradient that are favourable for esophageal emptying. What about some inferences regarding esophageal motor function? The concept of deglutative inhibition is well understood. In Chicago 4, we are using distal latency, a pressure-only parameter, to define this aspect of esophageal physiology. If we, however, record impedance, we now know that we are recording a representation of how the lumen is being distended, which is being aided by activation of inhibitory neurons that regulate muscle relaxation below the bolus and excitatory neurons that regulate propulsion. The new paradigms of pressure flow analysis and neuromechanical states may provide inferences regarding deglutative inhibition during bolus passage. This is a very interesting paper from Dr. Mittal's group, just published, which highlights the potential value of paying more attention to features of the intrabolus domain. In this case, showing that patients with functional dysphagia, compared to non-dysphagic controls, show an altered pattern of flow timing and distension, particularly in the most distal esophageal segment. In dysphagic patients, thin liquid bolus swallows transit quicker and had a reduced bolus distension area. It is suggested that these changes may be markers of neural inhibition. In several early papers that employed pressure flow analysis approach, we also reported subtle differences in distension timing and postulated that this may reflect neural inhibition. However, an important difference was that we appeared to be seeing evidence of bolus distension wave transiting closer to rather than further from the contraction wave. A possible explanation for this discrepancy may be the type of bolus that was being used. In our case, significant differences we found when we used a viscous bolus. To illustrate this point, I'm showing here some recordings from a healthy participant being given the fast-acting opioid drug remifentanil. Opioids block neurotransmission, leading to motor patterns such as a shorter distal latency, suggesting loss of descending inhibition. As you can see via the purple maximum distension line, this passage of liquid bolus is indeed more rapid, leading to a markedly shorter swallowed to distension latency, which is the blue, and a longer distension to contraction latency, which is the orange. However, a different pattern is seen when a viscous consistency bolus is swallowed, whereby both of the timing measures are shorter due to the bolus distension wave transiting closer to the contraction wave. When we look at these swallows via more granular pressure admittance maps, you can see how exposure to the opioid changes the timing and duration of distension of the distal esophagus. In the time remaining, I'm going to discuss EGJ outflow obstruction. So by definition, EGJ outflow obstruction is an obstructed esophageal emptying in the context of pulsive peristalsis, often leading to compartmentalized pressurization of the distal esophagus. Absence of this pressurization being suggestive of an erroneous IRP4 reading. In addition, in Chicago Classification 4, several steps have been taken to improve specificity of the IRP, including consideration of referral symptoms, protocol changes, upright swallow, rapid drink challenge, solids, and also adjunct imaging or endoflip. There are several bolus domain measures that have potential to improve the accuracy of EGJ diagnosis. These include the impedance-guided intrabolus pressure, mapped to the maximum distension, the ramp pressure, quantifying the rate of pressure change as the bolus is pressurized between the esophagogastric junction and the contractile front, and EGJ bolus flow time. In this F&M poster from our group by first author Charles Koch, we examined which of these adjunct measures have potential to assist in the diagnosis of EGJ outflow obstruction. Importantly, this study quantified the type and degree of bolus hold-up perception in a group of EGJ outflow patients. Of the measures evaluated, the ramp pressure to viscous bolus challenges differentiated those patients with bolus transit symptoms. So hopefully I've given you a taste for what physiological measures may be around the corner for Chicago version 5. In relation to where we are right now, we need to recognize that impedance, despite its potential value, is not uniformly available. If we examine the medical literature over the last decade, it's clear that 25% of countries produce 75% of the original peer-reviewed HRM literature, and that even within the most active countries, only the minority of published articles present data derived by combined impedance. This represents a significant challenge, and we need to look to our colleagues in the device industry to help with this transformation, perhaps by providing impedance as an opt-out rather than an opt-in feature. Thank you very much for your attention.